So in terms of scanning, I've been scanning for 30 years and my shoulder's wrecked. And I would say to you is one important thing is getting the setup for how the patient is on the couch. So the patient is very close to me, so I'm not scanning at a distance. And then I rest my shoulder. Thanks very much. I just want to have a quick look at where we are with time. So live's going 10:20 and we're 10:40, 20 minutes behind. Okay. So I'm starting off with a cardiac assessment, and the patient is 20 weeks and 5 days of gestation. And for me, the workhorse probe I start is with a probe of C2 to 9. And then in a general sweep, I'm going to start a sweep coming down to the urinary bladder, and then from up here, sweep up to the fundus, and then sweep from right and sweep to left. So if we look at it, the baby is pointing down, we have slightly transverse, this baby. So we have the head over towards the right iliac fossa. So the next I see the baby's in sort of a spine up position. So in a scenario when I'm in sort of a spine up position, I'm going to have to do a little bit of negotiation. So the first thing is, before I even go to my cardiac, is I'm going to open my sector width, because I want to get a global picture of what the lie of the land is. So I'm going to come down now, and then I'll probably use my other hand to try and get the baby into a better position. So I'm just going to be a bit of a gentle, and I'm going to try the other way. So it's quite flexed. So what I'm going to do is I'm going to try and get the baby just to move. Can I have an extra hand, helping hand? So in terms of trying to get the baby to turn, you find that if you keep a little bit of pressure on frequently, that the baby's with time will shift. So in this position, I'm going to start off with the basic assessment. So I'm going to, first of all, take down my sector width. I'm going to reduce my depth. And we say the head is down the right iliac fossa and heading up to the spine to the left. And then I check that the stomach is on the left-hand side. I'm going to reduce my depth further. I'm going to split the screen. So I'm confirming that the stomach is on the left. And then I update the screen, and I see that I have the heart on the same side as the stomach. And that's the first image that I'm going to save to a file. So as I come down to looking at the level of the stomach, I come back to a full screen, and I'm going to just reduce my depth slightly, slight total zoom. And as I'm looking at the cord insertion, I have this point here. This is the anterior abdominal wall cord insertion, and I follow the course of the intrahepatic vein. As I look at the course of the intrahepatic vein curves away from the stomach. So if we look at the stomach here, intrahepatic vein and the gallbladder. If you want to, in that setting, you can then use power Doppler. And as you're using power Doppler, one of the rule of thumb is just make sure that you reduce your box to the exact area where you are imaging. And as you come in here, we see the intrahepatic portion of the umbilical vein, and then we see it then dividing to anterior and posterior branches, and it receives here superior, middle, and inferior branches, the intrahepatic vein. And my order is correct of stomach, intrahepatic vein, and gallbladder with a J hook appearance. The aorta I see is to the left of the spine, and the IVC is anterior and to the right. So if I look at my ISOUG first section analysis, I can see that everything appears normal. If you are struggling, and I would say if you're in the first trimester of pregnancy, you have the option of then choosing slow flow. And for that, what I go into is to select a map of 4, and then come out of that, and then I take down my gain. And this allows you to see just not only the direction of the intrahepatic vein, but allows you to see the tiny branches. This becomes important in the setting of portosystemic shunts, and we will talk about this with absent ductus venosus. I think it's on tomorrow's program. If you see, as you're looking here, you can see the movement of mom's breathing, and I might just ask you to stop breathing for 1 second. And if you do so when you're looking at fine vessels, by simply asking the mother to hold her breath, to asking the fetus to stay steady, you breathe very normally. Again, this becomes important of any cardiac imaging of tiny vessels. But for a section 1 analysis, in a sense, I'm happy how things look there. So next is to move up to the 4-chamber view of heart. So we're still in a tricky position, but I'm just going to try, and if this is uncomfortable, please shout at me, okay? So the next is to look at the 4-chamber view of heart. So I'm going to HD zoom. Now I'm going to move to a cardiac preset. So by force of habit, I do reduce sector width and depth, but you can also, if you want, use to go to HD zoom. And starting off with the rule of thumb that this is the descending aorta, therefore this is the left atrium, this is the left ventricle, this is the right ventricle, and this is the right atrium. And you're looking at the symmetry of the atria, you're looking at the symmetry of the ventricles, you're looking at seeing the moderator band inside the right ventricle, you're looking, bring the apex up, the apex down to 7 o'clock. In this position, I'm looking at the AV valves. I will not be able to assess whether there is offset of the AV valves in this position. I will need the baby to be in more apex up position. But at the same time, I'm using cine loop. As I slow it down, I'm looking at the opening and closure of the valves. At the same point as looking at this, I see coming into the left atrium, I'm looking to see the pulmonary veins here entering into the left atrium. You okay? Yeah, feel a bit lightheaded. So mum's just feeling a little bit lightheaded, so we're just going to get turned aside. Okay. The other option is if you want to bring in the other patient if she's feeling lightheaded. Yeah. We'll just wait for a second. So while we're just waiting for mum to recover, I did pre-scan a little bit earlier on. I'm just going to show you these clips. So this is an example just showing you a clip which is a split image. It's showing at this point here the pulmonary veins entering into the left atrium. So this is the descending aorta defining the left atrium, the left ventricle, the right ventricle, and the right atrium. As you look at this also, you can then turn your cine loop down. So if we take that down to 50%, down to 50%, and the advantage of turning it down to 50% is that each time during ventricular systole, I'm looking to see is if there's any evidence of regurgitant jet going across the right AV valve. How do I know where the right AV valve is? Well, there's the aorta, left atrium, right ventricle, and I have a split image because I see here the opening and closure of the tricuspid valve, and at the same time I'm looking at this with color Doppler. I'm seeing that there's laminar flow across the AV valve, and during ventricular systole that there is no regurgitant jet. When I draw a line from here to this point up to the sternum, I appreciate that 2/3 of the heart is in the left hemithorax and 1/3 is in the right hemithorax. I've already established that the heart is on the left side. When I look at the size of the heart, which I don't need to calculate a cardiothoracic ratio, but I look at that, I can see that that is less than 50%. So in a 4-chamber view of heart assessment on this baby, I can see that the key structures look normal. I just get rid of my text, and then I go back to the native rate. And doing so, I've got also in the baby, we've got the moderator band in view. And again, that becomes important because if you ever see the moderator band in the sonographic left ventricle, it'll bring you to a diagnosis of congenitally corrected. When I look at this, I slow down and I see that the offset of the valve insertion. So here, this is the tricuspid valve with the septal leaflet coming into view here, and here is the mitral valve coming into view. And you can see that the tricuspid valve leaflet is closer to the apex of the heart when compared to the mitral valve. When looking at it in the babies, same baby just scanned a little bit earlier on in terms of looking at the pulmonary veins, by turning down your balance, again reducing your cine loop, we can also see the point of the pulmonary veins entering into the left atrium. And I'll slow that down even slower, is because sometimes the pulmonary veins look as though that they form, in a sense, a channel posterior to the left atrium, and it may be difficult to prove that they are connecting directly into the left atrium. In this baby, I can see that it's connecting directly, but if I'm ever in doubt, then I will go to a split image and confirm that the pulmonary veins are entering normally. We're feeling a bit better? Yep. So we just go back to live scanning. So we just go back to looking at where we were with the 4-chamber view. And since I've shown you just that, I'm going to move, just in the interest of time, to move to the left ventricular outflow tract. So when you come up to the 4-chamber view, it's simply a rotational motion that will bring the left ventricular outflow tract into view. And when you're looking at the left ventricular outflow tract, you're looking at, 1, the continuity of the anterior wall with the aorta with the interventricular septum. 2, you're looking to see that the aortic valve disappears during ventricular systole. It's gone completely. If there's any evidence of it still being there, it may be one of the first signs of a bicuspid aortic valve or aortic stenosis. 3, you're looking to see the curvature of the aorta coming out of the left ventricle. And then on color Doppler examination, you're going to be looking to see that there's laminar flow. So for this, I have got a PRF on the top left-hand corner. I don't know if you can see that, but my PRF setting is at 40 centimeters. So the next step is to increase my PRF. If you remember on that chart, the mean was around 55 centimeters. I'll settle for 50. My box size is too big, so I'm going to reduce my box size just to look at the left ventricular outflow tract. I'm then going to go to the point where I split into 2D and on color, and then I'm going to total zoom until I've got it on view. Now I'm asking myself the question, if I look at that, that's a lousy left ventricular outflow tract, which I'm showing you there now. And you know why? Because my PRF is at 30 centimeters a second. Here's a very important point. When you are looking at control for color in assessing the heart, there's an order in how you do things. The first order of how you do things is you get your PRF correct. So the PRF has to be set correct for the vessel and for the gestation that you are looking at. So I'm getting the vessel at here. I've gone up to 55 centimeters a second. The next control I have is a power output I have at 89%. If I feel that that vessel is overrepresented with color, I will pull back on my power. If I feel it's underrepresented, I will increase the power. And then only after that will I then fine-tune with color gain. So the order is PRF, power, and color gain for looking at any vessel. As I look across that left ventricular outflow tract, I see that there's laminar flow, and that color, by comparing this screen, I can see that that is representative flow. Why am I making such a big deal about that? Is because I think we make a lot of our false positive and false negative calls of coarc because our color Doppler settings are not correct. Okay, so next let's move to a right ventricular outflow tract. So I'm going to go to a 4-chamber view of heart. So again, HD zoom. And the movement to get a right ventricular outflow tract is to fan up towards the baby's head. And in this view, and fanning towards the baby's head, it brings into view what we call the 3-vessel view. So I have some of the right ventricular wall in view, I have the pulmonary valve, the aorta, and the SVC. And if I pull back and rotate the transducer, remember I talked about looking for outflow tract VSDs, when I rotate the transducer, it brings into view the right pulmonary artery. When I look at the right pulmonary artery, that should always be smaller than the aorta. When I've demonstrated on 2D, when I fix my eye on the right ventricle with that very slight movement to bring the pulmonary valve into view, I then increase my gain, toddle my zoom, and I look at that pulmonary valve because the pulmonary valve is more difficult to visualize when compared to the aortic valve. And I ask myself, does that disappear completely during ventricular systole? Once I have that on view, I then go to my color. Now, with regard to the velocities inside the great arteries, they are slightly higher than they are for the atria and the ventricle. So I've increased my PRF and I've gone up to 75. When I've got my pulmonary artery in view, I narrow my box just to look at the level of the pulmonary valve. Now I do into a split image, and I'm actually looking at my left image ignoring what I'm seeing on the right, but on the left to see that I have the pulmonary valve in view. Why do I do that? Because when you have color on, you can't actually see the pulmonary valve unless you go down to the cine loop and look for ventricular diastole. So once I've got that, I can see there's laminar flow across the pulmonary artery. And now look at the moving up from the three-vessel view. I then move up to my three-vessel tracheal view. And for that, I'm just going to come back to my four-chamber view of heart. And to get to the three-vessel tracheal view, you simply go back to your four-chamber and you angle up to the cephalad. And now you can see the point on 2D. To sharpen that up, I'm going to increase my dynamic range. I'm going to select color. And there's too much color if I look on that aorta. So now I go back into my menu, I update, I split the screen, and now I'm going to pull, my PRF is okay at 70, I'm going to pull back on my acoustic output, and I'm also going to pull back on my color gain. And at this level, I'm then going to look at the size of the isthmus of the aorta. Again, very magnified image, color box just over the three-vessel tracheal view. And I look to see there's laminar flow across that. The vessel that's closest to the trachea, which is here, is the transverse aortic arch. Then I'll finish up because I want to leave time for Q&A. Just some other little practical points. Is when you're looking at to get the IVC, SVC, if we come across and get a four-chamber view of heart, if you catch find the left atrium, you see the pulmonary veins coming in on both sides, bring the right atrium into view and fix your attention on the right atrium. And with the right atrium in view, you can use your other hand and then just simply rotate on the right atrium to bring your SVC, IVC into view. And now if we come across that, we have our IVC coming in here and our SVC. So the way to get the IVC, or what's called the bull's horns view, so here is our IVC here, and here's our SVC up here. And the quickest way to bring that in is simply by going to your right atrium, finding your right atrium, and rotating on the right atrium to bring your SVC, IVC into view. Since the baby's in a position showing the arches, we might just select that too. I will clear our screen. And as you come across in the arches, we're looking to see, again, if you ever see on the three-vessel tracheal view that you have narrowing of the isthmus, it's then that you get to the point of looking at the aortic. By the way, how to get the aortic arch, let me take one step back. You need to confirm this on a sagittal imaging. One way, in a sense of a quick way of getting to an aortic arch view is to go back to the stomach and get a perfect stomach view. What do I mean by perfect stomach view? Well, I want to see a full length of the rib. So if I've got a rib here and a rib here, I don't want to see three ribs. I don't want an oblique section. And once I see that I have a full rib and the stomach in view, then if I rotate 90 degrees to that, then that should bring my aortic arch into view. It's just another way a quick way of getting to an aortic arch. When you've got your aortic arch in view, then put up on color. You can also choose power. If you want to get to the point where you're catching your neck vessels coming off, I have to try and get the right section here. So rotate. So the aortic arch is a much narrower arch when compared to the ductal. So that's the ductal arch. And you can see coming in, we also can see the ductus venosus, whereas the aortic arch is a much tighter arch. If we come across starting with the ductal arch, I'm going to reduce my PRF, increase my gain, and then pull back on my 2D gain. And this is referred to as the Canadian hockey stick appearance of the ductal arch. It's also a nice view for looking at here, coming in the tricuspid valve and the pulmonary valve. This is also the view in which you will see outflow tract VSD. So I spoke about going from a 5-chamber rotating to bring the RPA into view, and then continue that point of rotation, split your image, and now you can see just at this point here is your pulmonary valve, your tricuspid valve, and your Mercedes-Benz sign of the aorta. It's from there that you will pick the outflow tract VSDs. I think we might move to Q&A. Thanks very much. Thank you.